Thank you for being here. So my name is Osama Kashlan. I'm going to be giving you a talk about the treatment of a grade 1 degenerative spondylolisthesis with a cortical screw TLIF. Okay, so this is my conflict of interest, nothing that's relevant. So what are cortical screws? For those in the audience that are not familiar with these, they're a different trajectory screw that is more medial to lateral, and that's in contrast to the regular lateral to medial trajectory. The traditional cortical screws have the trajectory shown here, and the reason why they're called cortical is they hit 3 cortical surfaces as are listed on this slide. There is a change to this technique, the more that Dr. Daffner talked about, the more midline cortical technique where you start slightly more lateral and then you aim more anterior, so you end up really stopping at the vertebral body up here in the front. So those are the midline cortical screws. Just like Dr. Daffner talked about, shown to have a much higher pull-out strength and insertional torque when compared to regular pedicle screws. The study that he showed about the midline cortical screws having even a higher pull-out force than the cement augmented screws is also present, so they're the strongest screws, especially when you take the midline approach. And this is true in osteoporosis too. This study here shows that even in patients that are osteoporotic, the neural arch cortical surfaces maintain their strength. So that's the reason why cortical trajectory screws in osteoporotic patients work very well. Other possible benefits is this is a study with a 40-month follow-up that shows that potentially there's a less adjacent segment degeneration, and whether that's from disruption of the facet when you're putting a more traditional screw trajectory, or whether that's from devascularization of the medial branch that innervates those joints and muscles, no one knows. But here you can see that there's clearly a less adjacent segment degeneration in the study group at 40 months, and this is comparing it to open traditional pedicle screws. What are some relative contraindications? So traditionally people said, don't do these for pars defects, but you could actually use these in pars defects. If the pars defect is low enough, you could start the trajectory above the pars defect, and if the pars defect is high, you can actually pin the fracture across it with a cortical trajectory. So that's why I said it's a relative contraindication, even though historically people thought that it is a contraindication to cortical trajectory screws. The other thing is fixation at S1, and what's the reason why? There's less cortical surface there. The pedicles are huge at S1, but this is something that actually Rock taught me, and this study here confirms, is if you go through the end plate, then you have a pretty strong screw. So really, cortical trajectory screws could be placed anywhere in the lumbar spine, including, in this case where it's an upper lumbar level that is affected. So what are some benefits over percutaneous screws? So better fixation in osteoporotic bone, safer because you're going from medial to lateral, so there's less ability to injure neural tissue. You avoid facet joint violation, and if you're doing a traditional, or what most people do for an MIS TLIF with the 2 Wiltse incisions, if you add those 2 together, it's still smaller than the incision, or it's bigger than the incision that you would use for a cortical trajectory screw TLIF. So this is a patient that came in with osteopenia, with cauda equina symptoms. You can see she's a large patient, so there's another benefit of the medial to lateral trajectory is that you don't have to have this big approach if you're doing this open. So this patient had a grade 1 spondylolisthesis, degenerative. You could do this with a robot because, again, with a medial to lateral trajectory, it's actually perfectly made for robotic use in these cases. You could do the cortical screws like that. So these are kind of a hybrid between the lateral cortical screws and the medial, so they don't go all the way out to the ventral surface, but they're longer than the more traditional approach for cortical screws. You could put an expandable cage, and you have a nice result. You can see the cages for these, a lot of times, they're more lateral because, especially in a larger patient, you have that column of the patient tissues that you have to fight through to get there. So that's my experience with it. So for a situation like this, you have an osteoporotic patient that has back and leg pain, has been optimized as much as possible what are the benefits of doing this approach, a cortical screw approach with a TLIF, rather than doing a lateral and either perc screws and relying on indirect decompression, or doing a laminectomy and doing screws with HA coating or with cement. So these are the things that I thought would be the most, at least to get you guys convinced that a cortical screw TLIF is a better option for these patients. So first, this could be performed in any patient. For the use of lateral with pedicle screws, if you have psoas anatomy that's not amenable, you can't do that procedure. If you have vascular anatomy that is not amenable to that procedure, you can't do it as well. So this is really one type of procedure that you could do for everybody. The second thing here is the direct decompression versus the plus minus indirect / direct decompression in the lateral screws, or lateral cage with pedicle screws. So for a cortical screw TLIF, you're going to get a good decompression every single time. You're not relying on indirect decompression at all. And that's important, because this is a recent meta-analysis that shows that about 10% of patients that you're relying on indirect decompression for don't get the symptom relief or have failure. So if you want to be 100% sure, you want to do a direct decompression. And especially for a patient, let's say if someone comes in with cauda equina symptoms or weakness, you really want to make sure that you give them the best chance of a decompression. So you could say with a lateral cage, you could do a prone lateral approach. Again, you have to have the right anatomy for that. At L4-5, it's going to be hard. If you're doing it through two different approaches, then you're going to have to flip the patient. You're going to have to go from lateral to a posterior approach, which is not ideal in terms of OR resources and cost. So that's one thing that I think the cortical screw TLIF would be better at. In terms of a bigger footprint, so you say, oh, I'm going to put the lateral cage because it's an osteoporotic patient. I really want to have the most apophyseal ring contact with the cage. But now with the new implants that are on the market that expand laterally, again, it's not as big as a lateral cage, and this is an example here of a patient that got a lateral cage and one of those cages that expands laterally. It's definitely bigger, but do you really need that extended size? I think with the new cages, you could get that bigger footprint via posterior approach. And then the last thing is there's a real risk of cement extravasation. A recent study showed that up to 80% of patients have cement extravasation if you're using cement through screws. So that's not a negligible risk, and you can have pulmonary emboli caused by that, which could be potentially fatal. So you don't really have that with the cortical trajectory screws. So with all that together, if you're the surgeon and you have the patient saying, you have to make me feel better, doctor, through one shot, and you have your boss or hospital system saying you have to decrease costs and do this right from the first time, then for me, it's a cortical screw TLIF. So thank you all so much.